Hi everyone, our subject today is Vesicle and Bullae in Pediatrics. Basics. Vesicle are small, half cm, fluid-filled lesion. Bullae are larger vesicles, half cm to 1 cm. Fluid may be clear or hemorrhagic. Vesiculobullous lesion, blisters, may be infectious or non-infectious. Non-infectious lesion may be spontaneous or induced by trauma or friction. Most vesiculobullous disorders are rare in children but need to be considered in a chronic blistering condition. Many are clinically indistinguishable from each other. Skin biopsy, immunofluorescence, and electron microscopy are often necessary to make definitive diagnosis. History. Bullous impetigo, exotoxin-mediated erythrodermal infection resulting in sloughing of the skin at the epidermal layer and can involve a buccal mucosa. Staphylococcal aureus most commonly is implicated, less commonly group A beta hemolytic streptococcus, comprising mainly of Streptococcus pyogenes. Fever, lymphadenopathy are occasionally present. Contact dermatitis, allergic lesions even beyond the area of contact, and contact-mediated lesion only where direct skin contact. Dyshidrotic eczema, history of eczema, hyperhidrosis, contact allergy like nickel. Epidermolysis bullosa involve an area of trauma, occasionally involve nails, hair, teeth, can sometimes be severely scarring, deforming, and life-threatening. Frostbite, prolonged exposure to cold resulting in tissue degeneration, denaturation, cellular dehydration at times, tissue death. Often digits are cold, firm, numb, and or burning. First degree epidermis to fourth degree epidermis, dermis, subcutaneous tissue. Hand, foot, mouth disease. A human enterovirus transmitted after oral ingestion of virus that is shed from the gastrointestinal or respiratory tract of the infected individuals. Once ingested, replication occurs in the intestinal tract, pharynx, lymph node, and eventually reticuloendothelial tissue and organ, skin, CNS, heart, liver. Herpes simplex virus, sudden onset of multiple vesicle fever and malaise. Only 25% with positive serology have a rash. Herpes zoster, rash is in a unilateral dermatological distribution, 1 to 3 dermatome, most often thoracic, systemic symptom in less than 20%. Usually there is a history of prior varicella infection. Pain, which may be burning, stabbing, or throbbing, often precede the rash. Id reaction, acute onset of pruritic erythematous papillovesicular lesion, 1 to 2 weeks after a primary skin lesion, infectious or inflammatory. Incognita pigmenti, rare X-linked dominant disease, presenting in infancy, vesicles, ocular, dental, and CNS involvement. Staphylococcal scaled skin syndrome, fever, irritability, initial blanching, erythema around nose, mouth, then diffuse flaccid blistering. Stevens-Johnson syndrome, toxic epidermal necrolysis, seen usually during the first 8 weeks of drug exposure, sulfa drug, non-steroidal anti-inflammatory, lamotrigine, phenobarbital, carbamazepine, mycoplasma infection, 1/3 without cause. Rash, fever, myalgia, and arthralgia. Urticaria pigmentosa, 75% occur in infancy. Pigmented lesion that blister after stroking or trauma, diarrhea sign. Intensely pruritic. isolated mastocytoma, usually of the wrist or generalized, rarely associated with the flushing, headache, dyspnea, wheezing, rhinorrhea, nausea, vomiting, diarrhea, and syncope due to histamine release. Varicella, in incubation period 14 to 16 days, vesicles follow fever, malaise, pharyngitis. Variola, smallpox, begin on the face, monomorphic stage of all lesion. Prodrome of fever, pharyngitis, headache, nausea, vomiting. Centrifugal spread, macules, papule, pustules, vesicle, has been mostly eradicated, but it is a potential bioterrorism agent. Physical examination. Bullous impetigo, small to large vesicles, bullae that quickly burst, leaving denuded skin. The face is the most common site. Many benign may begin as non-bullous impetigo with the honey-colored crust and pustules over the erythematous base. Contact dermatitis, localized, characterized shape like a circular lesion of the nickel watch or a linear area where poison ivy brushed against the skin. Erythema, underlying vesicular lesion. Dyshidrotic eczema, a pruritic vesicle usually on hand for weeks, then desequumate. Epidermolysis bullosa, diffuse bully of the hand and feet and often the entire body. More severe forms have joint contracture, deformity, organ involvement, sepsis, and death. Frostbite, first degree, waxy skin, erythema, hard, numb. Second degree, erythema, edema, vesicles. Third degree, a blood-filled vesicle progressing to scar formation in weeks. Fourth degree, deep tissue damage and loss. Hand, foot, mouth disease. Hand, foot, and mouth vesicle, usually posterior oropharynx lesion at time, other parts of body involved. Eczema coxsackium has extenuated lesion in area of eczematous dermatitis. Herpes zoster, dermatomal erythematous base, vesicular, pustular, or crusting, painful, all in the same stage. Lymphadenopathy, conjunctival keratitis, rarely meningoencephalitis. Herpes simplex virus, vesicle on an erythematous base, anterior mouth lesion, genital lesion, finger or toes lesion, herpetic whitlow, keratoconjunctivitis. Adreaction, distant from primary infection site, localized or more commonly diffuse. Symmetric crop of erythematous papule, vesicle, bullae on palm and lateral aspect of finger, occasionally sole and toe. With the long-standing disease, fingernail may become dystrophic. Incognita pigmenti, several stages of lesion beginning with the linear vesicle and hyperpigmentation during infancy. Scabies, linear burrow, excoriated papule that can become vesicular. Staphylococcal scald skin syndrome, warm erythematous skin that quickly progress to widespread bullae, sheet-like wrinkling of the skin and sloughing. Bullae exfoliate in large sheet, Nikolsky sign. Stevens-Johnson syndrome, toxic epidermolysis necrosis, target lesion, erythematous macule that coalesce and can become frank bullae that shear easily, leaving denuded skin. Urticaria pigmentosa, several tan brown lesions, mostly on the trunk, some vesicle, varicella, papule, vesicule, and pustule on erythematous base in various stages. Variola, lesion on the same stage begin on the face as macules and then papules, vesicle, pustules, then crust, toxic appearing. How to approach to child with the vesicles and bullae after performing history and physical examination. If the presentation within the first 1 to 2 months of age, this is neonatal, will be discussed in another lecture. If it is later presentation, is there systemic illness present? If it is yes, differential diagnosis, varicella, hand, foot, mouth disease, staphylococcal scald skin syndrome, Stevens-Johnson syndrome, toxic epidermal necrolysis, acrodermatitis enteropathica. If there is no systemic illness present, if it is localized or generalized. If it is generalized distribution, differential diagnosis, scabies, bullous impetigo, erythema multiforme, linear IgA dermatosis, epidermolysis bullosa, dermatitis herpetiformis, pemphigus, fixed drug reaction, mastocytosis, bullous urticaria pigmentosa, pityriasis rosea, lichenoides, et varioliformis acuta. If it is localized distribution, differential diagnosis, bullous impetigo, contact dermatitis, insect bite, burns, friction, herpes simplex, herpes zoster, dyshidrotic eczema, tinea pedis, scabies, pemphigus, epidermolysis bullosa, blistering distal dactylitis, fixed drug reaction, lymphangioma, acrodermatitis enteropathica, photosensitivity reaction, sunburn, drug reaction, genetic disorder with the photosensitivity, inborn error of metabolism, porphyria, skin disease exacerbated or precipitated by light, lupus erythematosus, drug-induced, diabetic bullae. Herpes simplex virus, PCR test and culture are diagnostic option for the herpes simplex virus. Zinc smear are of limited usefulness because they are not very sensitive, plus will not distinguish between herpes zoster and varicella. Staphylococcal scald skin syndrome is an exfoliative dermatitis characterized by diffuse tender erythema, flaccid bullae, sheets of desquamation skin, and a positive Nicolaski sign, blistering elicited by light touching. The face, neck, groin, and axilla are most commonly affected. Epidermolysis bullosa constitute a group of inherited blistering disorder, autosomal recessive or dominant, blistering at intraepidermal, intralamina, lucida, or subbasal lamina area of the skin. The clinical severity, age of the presentation, and level site of skin cleavage vary. Blistering may be spontaneous or in response to pressure or trauma. Most variants become evident in the neonatal period. The most common variant, epidermolysis bullosa simplex of the hands and feet, which is called Weber-Cockayne syndrome, may not manifest until adolescent or young adulthood, with the blisters developing on the hands and feet after significant trauma or friction, especially in hot weather conditions. The lesion of bullous impetigo are flaccid bullae that rupture easily, leaving superficial erosion. This form of impetigo is much less common than the non-bullous form, a crusted lesion. In the newborn, the diaper area is most commonly affected. The skin lesion of acrodermatitis enteropathica can be vesiculobullous or psoriform in nature. They are likely to be found in acral or oral and perianal lesion. Vesicles are more a commonly manifestation of scabies in infant and young children than in older children. They are most likely to be found on the palm and the sole and in the axilla and groin, with the typical pruritic burrow found on the web space of the finger. Severe pruritus is characteristic. It is often misdiagnosed as eczema, prolonging the patient's suffering. Erythema multiforme is a blistering hypersensitivity reaction classically characterized by target lesion. Target lesions are well-demarcated, round or oval macules with a distinct ring outermost erythema surrounding a whitish ring and then a central dusky blue-gray or blistered center. The typical size range from 1 to 3 cm. A self-limited outbreak of target lesion occurs in Erythema multiforme. The outbreak is usually symmetric and involving primarily the upper extremity. Limited involvement of one mucosal surface may occur. Many types of infectious agent has been associated with Erythema multiforme. Herpes simplex virus is the most common. Linear immunoglobulin IgA disease, a chronic bullous dermatosis of children, usually occur in the preschool years. The disorder is characterized by a widespread eruption of large sausage-shaped bullae with a variable degree of pruritus. The inguinal region, lower trunk, buttock, leg, and tops of the feet are most commonly affected, but the bullae may develop anywhere. Sometimes the bullae develop in an annular or rosette-like configuration surrounding a central cluster of jewelries. In Dermatitis herpetiformis, outbreak of cluster of the small papule and vesicle occur in a symmetric distribution on extensor surface, lower trunk, and buttocks. The outbreaks are extremely pruritic and tender. Hemorrhagic bullae on the palm and sole occasionally occur. The disorder is associated with the gluten-sensitive enteropathy. The term pemphigus encompasses a group of characteristic chronic blistering disorder with variable severity and prognosis. The characteristic lesions are flaccid bullae with the subsequent shallow erosion. Onset in childhood is rare. There is an infantile subtype with a prediction for acral region and a childhood vulvar subtype. In the pemphigus vulgaris variant, painful oral lesion may precede cutaneous involvement by weeks or months. Recurrent outbreak of a small pruritic vesicle on the hand and feet occur in dyshidrotic eczema. Larger vesicle and bullae sometimes occur. The palm, sole, and lateral aspects of the fingers and toes are most commonly affected. Stevens-Johnson syndrome is a more severe, potentially life-threatening blistering hypersensitivity reaction. It is often characterized by target lesion in a more extensive distribution than in Erythema multiforme and require involvement of two or more mucosal surface, mouth, eye, urogenital, esophageal, for diagnosis. Mycoplasma pneumonia is the most common pathogen associated with the Stevens-Johnson syndrome. Several medications are also recognized precipitants. Drugs are more likely to be associated with the Stevens-Johnson syndrome than Erythema multiforme. Toxic epidermal necrolysis is identified as severe form of Stevens-Johnson syndrome, with the prodrome of fever and malaise and a subsequent severe dermatitis, including some bullae, with the exfoliation of large sheets of full-thickness epidermis. It is most commonly precipitated by drugs. Naproxen, a non-steroidal anti-inflammatory drug used as an inflammatory agent in rheumatic disease, may cause eruption characterized by erythema, vesicle, and shallow atrophic scar after sun exposure. Hand-foot-mouth disease is a viral, usually due to Coxsackie or enterovirus. Illness characterized by a prodrome of fever, anorexia, and sore throat, followed by an enanthem of small ulcerating oral vesicles. The characteristic exanthem of oval vesicles, when it occurs, affect primarily the hands and feet, occasionally include elbow, knee, buttocks, and develops after oral lesion. Vesicles can also be seen with the other enteroviral infection. An inflammatory vesicular reaction may occasionally occur with tinea pedis. Peers and pitfall. Several diseases with the severe morbidity and or mortality may cause vesiculobullous disease. A vesiculobullous rash requires a careful evaluation to exclude such severe condition and to ensure timely and appropriate treatment if they are present. Herpes zoster lesion on the tips of the nose signify nasociliary nerve involvement. This mandates slit lamp exam with a fluorescent stain to look for dendritic corneal lesion for herpetic keratitis. Incision or puncturing bullae should not be performed as this may induce infection. Thank you for your listening.